By introducing myself, my name is Dr. Christina Kadama, and we have Dr. Philippa Kadama and Dr. Tina Kadama in the Purposeful team behind all this. You're most welcome this morning. It's nice and bright in Bugolobi. I just want to remind all the adults to have a bottle of water or a glass of water beside themselves as we go through this session this morning. Good morning, everyone. Good morning, old adults. Good morning, caregivers, and good morning, friends. Purposeful Aging Team welcomes you to this second session, virtual session in 2025. Thank you for logging on early. I know that traffic jams all over Kampala can make it a bit hard for people to get to places where they are, but you are here virtually and you're most welcome. It's a wonderful occasion this morning. We are going to have a great session. Topic is a layman's guide to identifying and understanding treatment options for common cancers. I'll just give a small background on cancers. I'm not trying to define it, but just a bit of background. Cancer is a disease that results from uncontrolled growth of cells affecting almost any part of the body. While it is particularly common among older adults, its impact goes beyond the individual. It affects the entire families. A cancer diagnosis can bring significant challenges, including an increased demand for caregiving, reduced earning potential, emotional and physical struggles. Patients and their loved ones often face mood changes, fatigue, pain, and the fear of mortality. These challenges can lead to depression and other mental illnesses. However, recognizing early warning signs of cancer is key to effective management and treatment. For this reason, today's session is particularly going to deal with identifying cancer early, explore treatment options, and learn how to create supportive environment for both patients and their families. Again, cancer is a long-term illness, and as part of purposeful aging, our goal is to equip ourselves with knowledge and tools to improve outcomes while fostering mutual support within our communities. This morning, we are going to have a participatory session as usual. And we encourage you to be actively engaged. Jot down your questions in the chat box, share personal experiences, and offer helpful tips to one another. As always, we shall have a Q&A segment where you have an opportunity to raise your hands and talk directly to the rest of us. I would like to now introduce our guest speaker. She has already arrived. She's been with us for the last 10 minutes, I think. We are deeply honored to have Dr. Victoria Walusansa, a distinguished Ugandan trained physician, and a senior consultant oncologist. About her CV, I'll shorten it. Dr. Walusansa holds a distinction of being the first Ugandan doctor to train in the Fred Hutch Cancer Research Institute in Seattle, USA. She currently serves as Deputy Director at the Uganda Cancer Institute, UCI, in Kampala here, and is the head of clinical services at the same institute. Additionally, she's a key member of the UCI Fred Hutch Collaboration Executive Committee. We are thrilled to have you, Dr. Victoria Walusansa, to join us today and share your expertise and insight. You're most welcome to Purposeful Aging. This is a space where older adults, caregivers come together to share experiences and learn from one another, particularly on the things beyond the hospital setting. Dr. Walusansa, at present, we have about 31 participants online, and they are all very anxiously waiting to get that wisdom from you, guidance on identifying and understanding treatment options for all those common cancers which keep us awake most of the time. You're most welcome, and thank you. You've got about 45 minutes to interact with us. Following that, we will have a Q&A. Thank you and welcome. Good morning, Dr. Walusansa.
Hello. Hello.
Hello, we can hear you well.
Thank you. Thank you for unmuting me. Good morning, members of Purposeful Aging. It's an honor. It's indeed an honor for me to be on this platform and to share knowledge. I believe I'm going to learn from you as well. I want to take this opportunity to thank Dr. Christine Kadama for the introduction. I have worked at the Cancer Institute. I think now it is 21 years. So I've grown at the Cancer Institute, and there's a lot I have seen that I would like to share with you today. I also want to thank Dr. Philippa. She passed slides as we were waiting that make my life very, very easy. And as said, we are here to understand the layman's we are here to understand the layman's understanding on identifying and understanding the treatment options for cancer, for common cancers in this country. I would like to begin this discussion by saying that the incidence of cancer increases dramatically with age, especially above 65. Okay, when you go, as you age, the cancer incidence increases. So the risk of anybody developing cancer increases. And true to the fact that world over, more than 50% of the patients with cancer are actually greater than 65 years of age. And it increases exponentially with age. And cancer deaths are highest in this age. And it is because there's an accumulation of the risk factors for all the specific cancers as someone ages. And this is doubled to the fact that also the cellular repair mechanisms are less effective, and they continue becoming less effective as we age, because the housekeeping would be the one that keeps in check all the abnormal cells, as Dr. Christine talked to us. And so cancer disproportionately affects older people, and I am excited to be in this place, because in this country we thought that people don't age, but in the last 2 In the last two census, we have noted that actually most of our people are aging, and the life expectancy rose from 44 to 56 to now 67. So as life expectancy increases for the different factors that have helped it to increase, we shall see more and more of cancer in our elderly people, in our aging people, and we should brace ourselves for it because we may not be prepared for it. We also have a challenge of people as they age, labeling themselves as elderly, and every complaint, every issue that comes on, every small ailment, every pain, every abnormal thing that they see, they mentally attribute it to old age. I think this is old age. I'm not passing stool properly. I think it's old age. It's because I'm not moving around as I used to move around. I'm now retired. And this is not only the patients who are going to attribute it to old age, but also the relatives and carers who will think that some of the symptoms that could be pointers to us acting are part of old age. So old age is labeled as a syndrome where even cancer and some of the symptoms that would be letting us act are labeled as old age. And so many times patients come in with advanced disease. Most elderly patients know about the causes of cancer, and indeed, most of us know that taking tobacco, alcohol, unhealthy diet, being inactive, all the elderly people know. And in this group, I know that everybody is working towards a healthy life, and all those things are not part of what their lifestyle is, or if it is, they are struggling to make sure they go out of it. And most of us know the tests that can be done for screening, which we shall go through. And also it's true that most people fear cancer treatment. They fear chemotherapy, they fear radiotherapy. This is a lived experience that I get with old people, and that most elderly people are anxious and get depressed about a cancer diagnosis. And sometimes this cancer diagnosis, sometimes the depression is masked in the cancer diagnosis, and the carers as well as the patient don't take time to treat it. Sometimes we put their attention to the cancer treatment and not looking at the depression, which many times accompanies the diagnosis. And it is important for us to remember that age is directly related to depression, even without cancer, because as you age, the social activities and social networks kind of start becoming smaller, and our social interaction kind of reduces, and we are at risk of getting depression. So it's very important, as Dr. Christine said, that we should look out for some of these things. As we age, it's important for us to underscore the importance of a religious coping for all the different challenges that aging brings, including cancer, including depression, and many of the elderly people, or as we age, we kind of find back our locus to church and to our religion as part of socialization and coping. One of the biggest challenges that has been noted is that many of the elderly people, when they are sick, or old people, when you have the younger generation, they do not get to participate in care. They do not get to ask the big questions. They will bring the children and talk to them, and the children will say, we don't want our parent to know. So many times the elderly people feel that they are pulled out of the diagnosis, knowing what is happening and what their chances are at treatment. But many of them would like to know and would like to play a role in their diagnosis and in their treatment planning, and knowing what their chances are in order for them to plan and prepare themselves. Because at the end of the day, we are all mortal. None of us is immortal. So today, as posted in our group, we know that in this country, the #1 cancer for men is prostate. It's closely followed by KS and esophagus. We also know that women, cervical cancer is twice as common as breast cancer, which is the next contender. These are the two most common cancers in women. But for both, we have to pay attention to the other silent cancers that come in, the stomach and esophagus. We are seeing more of that. And then in women, we are also seeing a lot of ovarian, it is important to note that for the special populations, the people who are aging and they have HIV, because of the wide okay, people are taking their ART. It is an uninterrupted treatment adherence. Kaposi sarcoma, which is a skin cancer, and non-Hodgkin's lymphoma, which is a lymphoid cancer, is not as common as it used to be. The figures 20 years, the figures 10 years ago were rather skewed. We saw more of non-Hodgkin's and Kaposi sarcoma even being one of the #1 cancers in men, and in women being the second. But now it is down because there is uninterrupted taking of ART, and we thank the government for that. And we encourage people who care for elderly people who are on ART for HIV to continue taking the treatment. And in fact, now, most of the patients who we see with HIV are coming in with the age-appropriate cancers. We are seeing more of the women who have HIV coming in with breast cancer, as the cancer diagnosis are not KS or non-Hodgkin's lymphoma. So, and it is important to know that also HIV accelerates aging. I would like to talk about the modifiable risks, which were mentioned here, that by and large, as I said, all of us know that cessation or not even starting tobacco use reduces the risk of cancer, all cancers. For that matter, every time we are interacting with a new cancer diagnosis, we ask about tobacco use. So tobacco on its own increases all the risk for all the cancers. Alcohol use is known to increase the risk for breast cancer. Physical inactivity also increases the risk for all cancers. And in that, the neighbor is the obesity. We should also look out for it and make sure that we control our weight as we age. And a diet that is low in whole grains and high in fat is also associated with an increased risk of the cancers that affect the digestive system. That means stomach, colon, all those cancers, their risk increases. And I must say we are getting an increase of these cancers silently. We see many of patients coming from a certain part of town, certain part of the country, especially in the West, coming in with with GI cancers because of their high milk intake and fat intake. A poor sleep hygiene is also associated with poop cancer, and because you don't rest and your inflammatory hormones are high, and not getting, I'm going to say this, not getting recommended cancer screening on time also increases the risk of you getting cancer, because many times when you do cancer screening that is rigorous, we are going to be able to see cancer in its pre-cancerous state before it has become cancer. We pick it and we do the appropriate treatment. And then infections that can be avoided, like HIV, infections that can be treated, like the Helicobacter H. pylori infection in the stomach, infections that can be vaccinated, like HPV and hepatitis B, also are known to cause cancer, to increase the risk of cancer. So that is something for us to take home. We also have the non-modifiable risk factors, and one of them that is here today, because as we age increases the risk of cancer. So as we age, we should be on the lookout for cancer, especially once you cross 40 years. And then the genetics are inherited. We never choose which family or which people are related to us. And in here, we have the BRCA gene, BRCA1, BRCA2, but we also have many hereditary genes that we are seeing in families. There are families where you find that 7 people have got the same cancer and you've treated them and they're okay. A family history of having a cancer, specific cancers, also increases cancers, and this is true for breast and prostate. And then the gender, there are cancers that are specific to women and cancers that are specific to men, and there are cancers that are more specific to people who are of a certain sex. So prostate is always seen in men, and cervix. Breast is seen more in women because of the hormone factors, and cervical is only the women who have the cervical cervix who can get cervical cancer. And then there are cancers that we are going to get because of our race. We are Black, and so there are many cancers that increase because of our sex, of our race. That is, pancreas is more in the Blacks, prostate is more in the Blacks, multiple myeloma is more in us people of African descent. There are other non-modifiable risks factors, but which can help if we know that they are there, especially things to do with the hereditary conditions like the familial adenomatous polyposis, which increases the risk of colon cancer, and then a past history of cancer. We are always on the lookout for other cancers and even a recurrence of the cancer that you were treated. It is important for us also. Remember, I wanted to first go through what we do when we suspect a cancer. As a layman, there are things that you're going to hear that I'm going to be talking about, like screening. I'm going to emphasize screening because screening at our age, as we age, regular screening helps us to pick cancers that are precancerous, to get cancer at its precancerous stage. And that way the treatment is less, it's associated with less morbidity or less side effects. It is quicker and it's associated with even higher cure rates as opposed to waiting for the cancer to develop and to progress. So we encourage screening, and then we shall talk about the screenable cancers. And once you've screened and there's something that they have said, they have seen that is suspicious, many times we shall ask for a biopsy. A biopsy is a piece of the abnormal area or tissue that they have seen that is taken and read by another specialized doctor, a pathologist, and many tests are carried out to further understand this abnormality and classify it either as a cancer or pre-cancer or no cancer or normal tissue. And those are the answers we expect when we do a biopsy, because something can look like a cancer when it's not a cancer, and it may look normal when it's actually a cancer. So there are answers that we get from a grade. It's very, very advisable that we get the biopsy. Many times we have problems because there is a hesitancy to have a biopsy. We have a common, there's a common belief in the non-medical people that when they touch cancer, cancer atambula, so they don't want to have a biopsy. I encourage us to know that a biopsy is actually good for us because it typifies and it gives us, it lays bare the truth about this abnormal growth that they have seen. Then it gives us the grade. It will tell the doctor whether this kind of cancer grows very fast, meaning the doctor should be very fast in treating, or this cancer grows slowly, meaning that he should sit down and discuss with you and see the best way it should be treated. And it also gives us the treatment options and gives us the chances. We are able to understand that this cancer carries a poor prognosis, a good prognosis, and that information is relayed to both the family and the patient to make them prepare themselves in this journey. After having the biopsy and confirming a diagnosis of cancer, the doctors will sit with the family and talk to them about staging. Whenever you hear the word staging, is to see whether the patient, the cancer that is within the patient has moved to different parts of their body. And there are parts of the body where it moves. So it will move locally and move distant. When it moves distant, you'll hear the word metastatic. Whenever you hear the word metastatic, it means that the cancer has gone to a distant place, and metastasis is the same as stage 4. Many patients want to know what is the stage. Many times I tell them, yes, the stage is important, but it's important to us and to you, and not to other people who are going to now take advantage of you because they've heard you have stage 4, which means that you are going to die. And sometimes patients think that stage 4 means that you're going to die tomorrow. But I have gone to conferences. If patients are treated well, I've gone to conferences where people were diagnosed with stage 4 and they were treated and they got better. So that is also something that I want to remove out of the patients, that when they tell them it's stage 4, they give up and they go away. They don't want to try any treatment because they think it's stage 4, but there's something that can be done for stage 4 also. So after staging, we do tests. They will ask you to do a CT scan. They may ask you to do a CT scan of the chest, abdomen, and brain, depending on which cancer they have seen and how it normally travels or moves around the body. That will be done. That will be requested for, and that information arms you and the doctor in knowing where the disease has gone, and it helps in the planning of the treatment and also understanding how much time we have, what is the aim of the treatment, because the aim of the treatment, whenever you hear palliation, it means that we are treating, but we don't know whether the cancer will completely go away. But when you know that the intention of treatment is cure, then that means that the tumor or the cancer is early. So we aim to treat it as aggressively as possible and to cure it completely out of the body. There is a new thing that I would like to talk about, the PET scan. The PET scan is like a CT scan. The only difference is that the patient takes a dye, which is taken up by the cancer cells that are growing very fast. And this dye can be specific to tissue, like the one for prostate, that is the PSMA, but it can be for sugar because all cells eat sugar. So they do a labeled radioactive labeled sugar. The patient takes it in. After a few minutes, the scan is done. And the areas that are taking up this sugar a lot are the areas that have cancer. We are able to see where it lights up and to know where it is, where the cancer has gone. This is very important because it's able to give you the whole picture of the body and show you that even if the patient doesn't have symptoms here, there are also deposits in different places. So that PET scan is not in the country. We normally send patients to Nairobi to have this PET scan, and it costs about $400 to $500. Nairobi has about 3 PET scans in the different hospitals at the Kenyatta Referral and Teaching and Training Hospital, Research Hospital, and as well as the Uganda Cancer. And there's another new center that has a PET scan. So we send patients there, but many times if the tumor is growing very fast, your clinician may decide that let them first treat and they will check. For example, if that the tests done in Uganda are showing that there is cancer in different places, it doesn't make sense for me to send you again for a PET scan because it is going to tell me exactly what I have seen. So normally what we do, we would treat you and then go and do the PET scan after we've treated you. It is important for us because many times people think that the PET scan is also treatment, which is not. PET scan is not treatment. It's not treatment. It is an investigation, and some of the investigations we do here can also give us the same information. But in as far as assessing treatment, it is very important for us to do it. And I want to talk about the other challenges that we have, that after we have staged, then we shall have a talk with the patient and the family. It is important that you don't let your patients who have cancer go for treatment alone, because many times in the first talks, when the patient has first gotten the first shock of the cancer diagnosis, they may listen, but they don't remember. And so such things come in that you didn't tell me what diagnosis I have. I don't know what stage I am. Normally, I encourage patients to have treatment buddies who we hold accountable, just like we used to do for HIV, that when they come in, we have that talk. And basically, sometimes if we see that there is a failure to cope, we also get in somebody, a cancer support groups or a cancer support person. There are organizations that work around Cancer Institute that help in supporting patients with a new cancer diagnosis, and basically they will give you a lived experience, as opposed to a patient thinking this doctor is just talking, they don't know what I'm going through. But this is somebody who has walked that journey and is talking that journey. So we walk through the counseling. If the patient is going to have treatment, we walk through the stage, we walk through the treatment that we are going to give, and we talk about the challenges that a patient will have as they are getting this treatment. And we emphasize the need for the patient to remain active. I normally tell my patients if they have any activity that they do, they continue doing it to the best of their ability, because also being bedridden is part of it's not therapeutic. Work is therapeutic in whatever form. Socialization is therapeutic in whatever form. And nutrition is very important. We talk also about nutrition. Feeding poorly is not going to help the cancer to get better, because there is a misconception among patients that cancer cells grow on sugar. So they should stop eating sugar, they should stop eating meat, they should stop taking milk. And remember, when they're on treatment, their appetite is not okay, but their energy and food requirements are high because there is a high rate of destruction of cells. So we get that mismatch, and that's why you see some of our patients losing weight, which shouldn't happen. So from the word go, we have that talk with the patient that they have to eat healthy. And if they're not eating, they should report. And if we don't have an attendant in the discussion, then this will go silent. So I encourage us to escort our patients and report everything that you see in the patient as you see them in this cancer journey. We also look out for depression and give some of the cardinal signs of depression, which I believe this has been discussed in this group. We give some of the cardinal signs where somebody has lost interest, they are giving out their things, they are not interested in being alive, they even willfully refuse treatment and they keep referring to death, they want to go. So we also address it and we have to treat it. So once that is done, we also go to the part of choosing the treatment. I want us to understand that we choose treatment depending on the type of cancer that the patient has, the grade, and all the other factors that we shall have found on the biopsy. And the other factors that decides on how we are going to choose the treatment protocol, and the treatment journey at the stage of the tumor. So that is very important. So the biopsy, the histology type, and the stage. And then there are patient factors also that we consider. If the patient is too old, the patient has other comorbidities that could affect this treatment. For example, we look out to see other diseases that also come with age, like hypertension, diabetes, cardiovascular disease, and other diseases that may be walking around in this patient. To make the full picture, we don't treat cancer in isolation, we treat it in totalis, and the approach today is a multidisciplinary approach that all the other members should also be part of it. It doesn't mean that because somebody has another disease, they shouldn't be offered treatment. With the right collaboration with the other team players, this patient can safely be given treatment. So we never give up on our patients just because they have other diseases. We never give up on our patients just because they have another very aggressive disease or because they are old. There's a misconception that old people shouldn't get chemotherapy. I give chemotherapy even up to 90 years if I feel that the patient is going to do well, because there are 90-year-olds who are actually very active, who I have in my care. But I will moderate and tone it down according to her system's function, because her organs are not functioning like a 30-year-old. So we shall tone it down, and we've had very good results as we look after these patients. There are also other factors that we look at. The other factors that we look at the side effects and how they are matched to this patient. We look at the social support. I am not going to be comfortable to give treatment to a patient who has very little social support, because after I have given treatment, I have committed, and I fear that I could actually just put down on the patient's quality of life by giving treatment. And that's why I emphasize the need for us to have carers escorting the elderly or aging patients as they come in for treatment, even for non-aging patients. The cost is also very important, because drugs for cancer, the newer drugs for cancer, you can find that you pay 20 million per dose, and somebody, you're forcing them to actually become bankrupt, or even give away everything that they had saved, which is meaningful to them. Because I don't think there's any parent who would like to leave their children indebted or with no inheritance. But as a family, when they sit, you give the cost and you look at the best drug within the costs, not compromising on the outcomes, but looking at what can be done. Because sometimes after assessing all these things and assessing the functionality and the performance of the patient, you may decide that we're not going to give treatment. We shall support and address all issues. Maybe at a later date we shall give, but at this time we shan't give. And we may opt for total palliative care, where total palliative care means that the palliative care team is in the driver's seat and we are behind, up to such a point where the palliative care team thinks that they can hand back the patient to us. And we always look out to address all the other challenges that the patient has, that they are comfortable. A patient having mental illness doesn't mean that they are not going to get chemotherapy, but we will bring a psychiatrist on board and make sure that they have a good social support who can help this patient go through treatment. And we also, as I said, talk about, we encourage, we work closely with cancer support groups like CASO. They've done a lot of work in breast about young girls, because we have cancer even in young people, but young and older people talking to patients and encouraging them to walk walk the journey, and assuring them that they will hold their hands as they walk through this journey of the cancer diagnosis and treatment. I have completed that, and I would want to pause a bit and then see if there's something that you'd want to talk about, because I wanted to go quickly and talk about the common cancers. I know that I'm talking to I'm talking to mainly aging ladies, but these ladies don't live in isolation. They also live with their husbands, their brothers, and maybe their children, hopefully. So I had prepared something for both men and women. I need guidance whether I should just talk about women cancers or talk about also some male cancers, and then the cancers that cut across.
Doctor, you can talk about the female or the male or the common ones for any sex, really. The audience is not only women.
Okay, thank you for that clarification. So I will begin with prostate. Having given that broad and quick, broad treatment, broad introduction, I want to talk a bit about chemotherapy. After chemotherapy, I'll talk about radiotherapy, and then I'll talk about the newer drugs, that is the targeted therapy. So I also want to make a correction that the PET scan is useful for tumors that are solid, that move and make small blocks, make small colonies. For blood cancers, it's very hard to use a PET scan to assess response, although some blood cancers also can make solid tumors as they progress. So after they have decided the treatment and we decide, sometimes a patient may present with a tumor or a cancer that is so big that surgery cannot be done up front. And in such circumstances, the team will discuss with the patient and the attendants that, let us do what we call neoadjuvant therapy. So neoadjuvant therapy means that we are giving you chemotherapy before we do surgery. And the aim of that is to reduce the cancer so that you have a better field. And we have registered very good results with that in many of the solid cancers, especially if they've come and it has locally spread widely. And even when they operate, they cannot be able to close, or they are going to leave a big defect, or even the possibility of completely excising is not there. We have seen good outcomes in that because we give chemotherapy, it reduces the tumor, the surgeon goes in and is able to cut it out in totalis. So when that is done, many times we find that some of our patients refuse to have surgery because the tumor will have shrunk, and they will think that, okay, let them continue with chemotherapy. Most of the solid tumors, we need to have surgery. When a doctor or the team tells you that from the word go, we are going to give you chemotherapy, shrink the tumor, and we do surgery. I have those challenges when the tumor completely melts away and the patient refuses to come back because they don't feel anything, only for it to come back 6 months down the road. So we do neoadjuvant chemotherapy, and then we follow it with surgery, or we can begin with surgery and then go and do what we call adjuvant chemotherapy. Chemotherapy there are many chemotherapeutic agents. We decide which chemotherapy the patient will use depending on the cancer. Different cancers have different chemotherapy combination or protocols, and we use them in different ways. Some of the chemotherapy may be given weekly, some of it may be given every 3 weeks, some of it may be given every 4 weeks, some of the chemotherapy is given by mouth, some of it is given IV. The side effects of chemotherapy that I would like us to know commonly is that weakness, and the weakness may come from many things, but the common cause of weakness is the immunity going down. And today we have drugs that help the immunity to come out. And when we anticipate that this patient, especially the aging patients, that is going to get immunosuppressed, we actually give a prophylactic booster. I will call it booster, but it's an immune booster. So it's an injection that will make your cells to grow much faster, even after the chemotherapy has gone down, has hit it. So the bone marrow is always working. So we give booster for that. And the weakness is because of that, but also sometimes because of not eating, because chemotherapy kills the taste and kills the appetite and may lead to nausea. All those things lead to patients not wanting to eat. So we also give a pre-medication which stops the vomiting during the chemotherapy, but we also give post-medication of an anti-vomiting drug that prevents the patients from having nausea, from vomiting, and encouraging them to eat. Sometimes chemotherapy, because of the way it is, because it kills cells, you may find that the mouth has wounds, because the mouth has the most rapidly growing cells. And when we start killing them, the mouth and the private parts will suffer more. So a patient usually have wounds both in the mouth and down. We give you first the booster, but also we give you antibiotics. And one of the things that we do, we also encourage patients to come with very cold ice drinks, preferably non-sugary, maybe just ice blocks to put in the mouth as they are getting chemotherapy, so that when the chemotherapy is passing the first time and the second time when we are giving it, it is not concentrating in the mouth. Most of our patients actually tell us when they use ice, when they put ice blocks in their mouth as chemotherapy is being given, they don't get much of that inflammation in the mouth, which leads to wounds. We also know some patients get diarrhea, we treat it. Some patients actually just feel nothing. So there are patients who come in and tell you, we don't feel anything, and they go through their chemotherapy. So mine is to tell us that we shouldn't fear chemotherapy if it's offered, but we should speak up on all the side effects and abnormal and discomforts that we get, because there's a solution to each one of them. If you have received chemotherapy, some cancers may just stop on just surgery and chemotherapy. Others may require you to have surgery. And that's when I emphasize the role of a multidisciplinary team, that we will refer to the appropriate surgeon who will do the surgery. But after surgery, it doesn't mean that the cancer has ended. You really need to come back, because we do a better follow-up. We have patients who have had colon cancer who had surgery, and after surgery, they just stayed down because they had told them everything had gone away. Yet actually the treatment does not stop at surgery. Sometimes at surgery, there may be things that spilled, or even at surgery, the doctor may think that the tumor only was there, but when it moved to other places, only for the patient to come back when where they operated is okay, but they have disease elsewhere. That's why we have to hold hands with even the surgeons as we treat cancer. So in cancer, it is important that after they've done surgery, even if your doctor or surgeon hasn't referred you, find your way to Cancer Institute or to a cancer specialist to find out if your cancer requires chemotherapy. If chemotherapy is done and surgery is done, many times you also send for radiation, because radiation is a local therapy to treat in the local area where they operated. And also this is a problem because many patients don't want radiotherapy. They feel that it is masanyalaze. I think some of them mentally, they think it is the UEB electricity, but actually when you go through radiotherapy, you don't feel anything. It's after they've radiated you that, and moreover for a long time, maybe for a week, that you start saying that, okay, this area is feeling abnormal, So I encourage us to go for radiation. And whatever anxieties that we have about radiotherapy, we share them with our doctors, and they will allay our anxiety. And if there are side effects, we share them and we treat them. There is a new form of treatment which we call targeted therapy. There are very many molecules that are on board. Maybe there are even more than 1,000 every day. There are new drugs that come for specific diseases that are used for cancers that are not responding. But as we have continued to use them, we actually are bringing them up front, because we've seen that their effects are much better, and some of them have even fewer side effects than chemotherapy. The challenge we have with some of these newer molecules is that they are more expensive. They are very expensive, and they are not readily available in the market. Some of them we actually order for them from India, and that's what people who go to India go to get. And it brings me to that point that if a molecule is known to give better outcomes and the patient is able to afford it, if brought up front, as opposed to waiting for the cancer to recur, it is incumbent upon us as the clinicians to share it with the patient and give it there. Of course, if they cannot afford it, then we shall use the traditional drug and be able and wait for when they are ready. but it shouldn't be the reason why we are waiting, because we are waiting to sell the house to buy the drug. Yet we have this drug, the old molecules, which could equally do the job. So you'll find that the way we are treating is that we go with the old protocols, and then maybe later when the disease is not responding to this, to the traditional medicine, then to traditional protocols of chemotherapy, then we bring in the new targeted medications. But the new studies have shown that some of these molecules, even when brought upfront, give us better outcomes. It's dependent on the cost and availability of funds, because many times these are the reasons why patients go abroad, and they have least, yet some of these drugs are actually cheaper here as opposed to the other side. And some of the targeted therapy, the government is able to buy to a certain degree for patients, and they can get it for free at Cancer Institute. The ones that they can't buy, we point out to them and they buy. And I think I have mentioned that there are many targeted therapies for the different cancers. I would like to quickly go to the common cancers in men, and I would like to talk about prostate. Because it's a common cancer. Previously, I said Kaposi sarcoma used to be the most common cancer, but with the advent of ARVs and highly active antiretroviral therapy, we now see prostate, and it has shown its ugly head. We have a lot of prostate cancer in this country, and much as they say that it is expected at age above 50, we've seen even 40-year-old. My youngest patient has been a 44-year-old patient who came with advanced prostate. Of course, as a clinician, you would think that this is not possible. This man is not old. And it's because of RS and some of the family history. So the risk of prostate increases with age above 50 years. And we are of African origin, so our risk is very high. And anybody with a family history of prostate cancer, anybody with a family history of breast cancer in their female relatives, and people who have a high fat diet and have weight also have an increased risk of developing prostate cancer. These risk factors were all mentioned earlier on the screen by Dr. Philippa. We encourage people to screen for prostate cancer. In the Western world, immediately you clock 40, if you're of African descent, that's the first birthday gift they'll give you. You go for a prostate screening, and for them, you go for the digital exams where the clinician fixes a finger in the rectum. But there are other screening activities, screening things that can be done, like the PSA. The PSA is a blood test where we follow up on the levels of the prostatic specific antigen to see if they are increasing or reducing. The other tests that are done, they can do a ultrasound, although most recently we use an ultrasound where they use a transrectal ultrasound, but that is for when they have seen something that is not tying up. So just having a routine PSA every year, especially if you have a risk factor, as mentioned above, it is very important for us to follow that.
Hello. Hello, doctor. We have lost you, Dr. Walusansa. Dr. Philippa, do you want to check on her?
Yes, I'll do that. She seems to have a network challenge. She has dropped off, but let me find out. Okay. So doctor has lost her network. So she's looking for a better place to connect. Let's give her a few minutes to reconnect and resume where we stopped off.
Thank you. In the meantime, thank you for the slides. Let's continue looking at the slides, especially if you hadn't seen them at the beginning.
Hello?
Yes, we can hear you, Dr. Victoria.
Mark, I don't know who put who off, but somehow I found myself talking to air. I'm really sorry.
You're welcome.
Really sorry for the glitch.
Sorry, we are at the
Hello?
prostate.
We're on prostate, and I think
We go
want
to
to share.
screening.
Yeah, to screen for it with PSA. And we say PSA, the prostatic specific antigen, and the test is done using blood. And where the tests are high or increasing, many times we request for a scan. And where the abdominal scan is, pelvic scan is not working, they may request for a scan that goes through the rectum. So it's for us to be aware of that. There are many stories that go around that eating many tomatoes, eating garlic, eating leeks, eating vegetables reduces the risk to prostate cancer. That is true. Let's go on those are vegetables, it's healthy eating. The symptoms that we should look out for is for a poor stream. If the man is saying that his stream is not going very far, meaning that he cannot take it far, the urine is always remaining near the thighs, it is something that requires us to report. And if there's frequent urination, especially at night, somebody wakes up like 4 or 5 times, it is something that requires also reporting. Somebody sees blood in urine, that's not good. And then there's that feeling of not completely. Every time somebody goes a few days, urine that remains, incomplete voiding is also a symptom that we should look out for and we report it. I'm saying this because I think one of the things that I mentioned as we began is that many times we think that the symptoms we have are due to old age, but everything that is abnormal and not normal, we should get into the habit of reporting it. So I've talked about those symptoms. And when that is reported, then the doctor will ask for the appropriate test, as I've said, to do a PSA and then to do a scan. And if there are any nodules, then ask for a biopsy. We began with a biopsy, and you'll understand how a biopsy for prostate is done. It can be done through the rectum again, and then it will give us information and we do the appropriate. But I think the onus is on the patient who has the symptoms reporting, and the rest takes its full journey. I want to talk about breast cancer because we are seeing more and more breast cancer, and it's anticipated that the incidence of breast cancer will increase by 2030. We shall have double the number of breast cancer incidents as we have today. And maybe it's because of increasing age, but also because of changing lifestyle. But we are seeing a lot of breast cancer, and breast cancer is a cancer that is directly associated with aging, just like prostate. And it increases, especially after, its risk increases, especially after menopause. And its risk also increases if there's a family history of breast cancer. And for ladies who had early onset of menses and late menopause, the risk is increased. And alcohol intake, we hear that a bottle of wine every day, is it a bottle, a glass of wine is healthy, but alcohol intake is directly related. It has a direct relationship with breast cancer. And also being inactive, lack of physical activity, and taking hormone replacement therapy. In this country, I don't think we do a lot of hormone replacement therapy, but in the Western world, they do. As somebody reaches menopause, the symptoms for menopause sometimes prompt patients to take hormone replacement therapy. And we as Africans have dense breasts, so our risk is higher because our breasts are not small, they are big. and reproductive history. In this generation, we've had fewer children than our mothers, and we continue to have even fewer. We hope our children will have more children. So having fewer children increases your risk, although at Cancer Institute, I also have women with 13 children, 17 children. So there's nothing that says that it's only this, but there are many things that tie up to increase the risk of someone with breast cancer. Obesity, we have a lot of food in this country, and obesity, the obesity index is high in this country, especially in women. So we have an increased risk of having breast cancer as we go forward. Age at first birth, because of education and because of the affirmative action for women, we are beginning we've delayed to have our first child. Most of us had children. Our mothers had children at 18. Some of us had children at maybe 10 years later than that. So the longer you take to have your first birth, the higher your risk of getting breast cancer. And many of us have that risk factor. We need to keep our weight. We need to be active. We need to stop alcohol intake. We should never smoke. If you are smoking, we should stop. And some of the younger generation, or some of us, think that the recreational tobacco like shisha is not bad. It is not. It is bad, actually. It's also tobacco. And anybody who is smoking, because we may think that we are not smoking, but when we are in a household where the other people are smoking, we are also smoking if other people around us are smoking. And that's a history sometimes we forget to take. The symptoms and signs, anybody who has a lump, you should report. If you see a change in the texture of your breast, the breast is hardening or it's looking like it has more dimples than it should. If the nipple is going back inside, and then you see the shape is changing, this should be reported. Even when there's just peeling and scaling or crusting of the breast nipple or the breast, we should report it. And basically, all of us should get into the habit of regularly checking our breasts. And even when we go for the physical, that yearly physical that we should go for, to make sure that a clinician examines the breasts, and to have the mammo regularly, at least every 3 years, to have a mammo as we examine, because as we age, the risk is high. We've had very good outcomes in patients who came with early breast cancer. We now see very many, especially older women, coming in with lesions that they didn't even know. They didn't have a symptom, they didn't have a sign, but they just went for a mammo and they had a lesion, and it's removed, and actually it's removed with the breast remaining on. So in breast cancer, many times we shall ask for that biopsy or a true cut biopsy. It is better than the fine needle aspirate because it's more effective. And once it gives us the diagnosis, then we shall plan. And as all cancers, we would like to have an early diagnosis because it is associated with less changes to the body shape and body everything, but also it has higher rates of cure. And most of our survivors came in early. And the treatment is going to follow what I have discussed before, that we shall do the biopsy to better understand what is this breast cancer, what is its grade, how does it behave, and how are we going to treat it. Because there are many, in one cancer, as they tell you it is breast cancer, there are about 3 or 4 or 5 different diseases in there, all of them being treated differently, all of them with different prognosis. So understanding with that biopsy how this cancer behaves, what are its receptors that it's showing out, is very important. Sometimes we see that that is a delay, but sometimes it's better for you to wait just a little bit and get the right information so that you can treat right from the word go. So I think those are things that I would like our attendants and us to understand, that when they ask you, do you have your estrogen receptor, your progesterone receptor, do you have the HER2 receptor? Those are all markers of aggressiveness of the disease, and they help in treatment planning and treatment initiation. I forgot to say that some of the cancers, it's not a one-touch treatment, unlike malaria, where we give antimalarials and the patient goes away. With cancer, it's a journey of treatment, and sometimes it has phases. We may have the induction treatment. Like for breast cancer, we have an induction treatment. which the aim is to induce remission, where remission is like the disease is controlled, okay, and it's not there. If we can't get remission, at least we reduce and we do a partial remission and do an additional treatment. So we do what we call consolidation therapy. Then we do local therapies, and many times we do a maintenance. In breast cancer, we have a maintenance depending on how the receptors were. And that's why it's important that we get receptor results. I am going to quickly also talk about CS cervix, which is the #1 cancer in this country for both men and women, although men don't get it, that it has the highest incidence in the country. And the most painful thing is that it's a cancer that can be prevented, but it speaks about us as a country. It speaks about also our high HIV rates in the past, that it's also spread by HPV, which HPV is going to take root in the cervix at an early age, the early exposure of young girls to sex and HPV. So HPV is a virus, and there are many strains, but the important ones are 5. And those are the ones that are being immunized for. I want to emphasize the need to immunize our girls, because we think that when we immunize them, we are stopping them from having children in the future. But HPV, the effects of HPV, we may not see them, but our children and grandchildren will see them. That's when the CS cervix incidences will go down as we continue to rally for immunization of young girls for HPV. So HPV is associated with almost 90% of all CS cervix, and the risk increases with sexual history, that people who have many lifetime sexual partners have a high risk of having HPV, because then the risk of infection is high. The age at sexual debut, people who have early sex definitely will have more sexual partners if they don't remain with the one who began the sexual activity. Smoking also increases the risk for CA cervix. The use of oral contraceptives has also been associated with another type of CS cervix that's not associated with HPV, obesity and weakened immune system. That's why we see a lot of HIV, many of the HIV, even younger women have CS cervix. And then other co-infections like the chlamydia infection has also been shown to increase the risk of CS cervix. HIV/AIDS, as I mentioned. The issue about CS cervix is for us to have regular screening. The regular screening is that we shall be able to see pre-malignant lesions that can be treated locally without chemotherapy and radiotherapy, and they can be cured. And the regular screening means that you're not doing it once and that is it, but you do it regularly as advised when you go for the screening. Why? As long as we are sexually active, or we were sexually active, then we can get CS cervix. But I know that after they have done many cervical screenings and they are all negative, and somebody is no longer sexually active, or because even if you're sexually active, you're not controlling the sexual activity of your partner. But for yourself, if you're not sexually active, sometimes they stop the screening, they say we have now stopped. But for people who are sexually active, regular screening for CS cervix should be done. And immunization can also be done for people who are not young girls, who are not young girls and who are not virgins. It is also being done, is recommended. And the signs and symptoms of early CS cervix. CS cervix can be there with no symptom. In its early pre-malignant or precancerous states, there's no symptom. That's why we have to screen even when we have no complaints and go and pick it early. But once it starts showing symptoms like bleeding, then it is there, and many times it has moved locally. So the common symptoms that we should report are problems to do with sex, where we have pain while having sex, we have bleeding after sex, or we have dull pain in the lower abdomen, we should ask to have that screening, and some of that to have the screening for CS cervix. And today there are also new guidelines that recommend just having an HPV screen, which will tell you whether you're at a risk of having CA cervix. So that if you are HPV positive with the bad strains, then you will know that you will have an increased rate of having to screen. And also CS cervix, like any other cancer, would require biopsy, and a decision would be made whether to require biopsy, but would also require examination and anesthesia, and decision will be made whether surgery should come or radiotherapy or chemotherapy should come before surgery, then radiotherapy. So the way this treatment is tandemly given out to the patient depends on what the examining doctor sees and what the stage informs the doctor. So I want to stop here and talk about some things that are some take homes that as old people, as older and aging people, we need to get out of the comfort zone of saying every symptom we have is related to age. No, it's not related to age. Let us report all the complaints or abnormal things that we see about our body. We ourselves know how our bodies have been working. We know how many times we should go to the toilet, because not going to the toilet and not opening bowels may not be a nice symptom. It may be something that is telling you that maybe your intestines are not working well, there's something blocking. We know our weight. We should aim to get a good weight, but also if we are losing weight in an abnormal way that we can't explain, we should report it, because it could be also a sign of cancer. Any pain, any arches, any swellings, any discharges, any abnormal feelings should be reported to the clinician, and we should get into the habit of screening for the common cancers that are sex appropriate routinely, maybe once every 2 years, to make sure that we are moving well. And that doesn't mean that we only have to go to the cancer doctors. We go to our other clinicians, like the physicians. We report many times. This comes in from the physician, because the physician will be able to further examine and send it to the appropriate person. Thank you for listening. I think I've taken a lot of time. That's why I'm rushing. I'm sorry. Thank you.
Thank you so much, Dr. Victoria Walusansa. This has been very, very informative. I'm sure not only the older adults, but the caregivers have got a lot to take away. You are more informed. The fears are now going to be all eliminated if we take the right steps as recommended. Next few minutes, we are going to have your comments, sharing, questions. If you want to raise your hand and share something, this is the time. Or if you want to put it in the chat room, please do so. And we share this great wisdom and much more, a lot more. And it's going to be regulated by Dr. Philippa Makanga. Dr. Philippa, please take it on.
All right, thank you very much, Dr. Christine. Dr. Walusansa, thank you very much. And I love the fact that you kept emphasizing to us that we should not keep assigning our health issues or changes in our bodies to old age, and we should have this checked out. That's a very important issue for all of us. And if we forget anything, at least we should remember that when we live today. So we have a few questions which have come into today. They encourage the audience to put up your hand and voice over if you have anything. In the meantime, Dr. Walusansa, there are two questions. The first one was, what are the broad dietary restrictions for cancer patients, if any? And the second question is where in Mulago can one have walk-in mammography and pap smear? You could take those two questions as we wait to hear from other participants. Thank you.
Thank you. The broad dietary restrictions, I gave the misconceptions. I shared the ones that I hear, that patients shouldn't take sugar, patients shouldn't take meat, patients shouldn't, everything out. But the broad dietary restriction I wouldn't give a restriction, but I would give an advice. Because sometimes we may have a patient whose appetite is so small and they have craved for chips and they're only going to eat 4 or 5 or at most 10 chips. And then you say, well, they stopped you from that. So I have that situation where I tell patients, if they are not eating well, to eat everything they can, which they feel they can. But ideally, our advice is to eat healthy. That will mean that a meal that doesn't have a lot of fat, or if it has fat, it has healthy fat. Fish fat is good. Because when you say you're not eating fish, patients will tell you that they also can't eat tilapia. They can't eat Nile perch because it's fatty, but fish fat is good. Red meat that is not fatty is good. White meat is good. Milk that is doesn't have a lot of fat is good. Eggs are good. Vegetables, all vegetables are good. Non-processed food is good. So I would give that as the broad strokes. And I know that the patients have a poor diet, poor appetite. So sometimes we're just coaxing the appetite. You can get a pap smear at Cancer Institute. It's a walk-in service. We have a daily screening, static clinic. You can have VIA. You can even have, if there's a pap smear, biopsy. And most of these hospitals around Kampala have been trained to do that in the new move to make sure that CS cervix is seen and treated as it is seen. Any abnormal cervical lesion is treated. You can have mammography at Cancer Institute. It costs 50,000 as you walk in. There's also mammography at Women's Hospital. And I'm sure also pap smear is there at Women's Hospital. The only thing that we have that women doesn't have is that we have pathology services. We're also able to do the HPV tests. Thank you.
Right, thank you very much. And I hope that has answered those two questions. There's another question about what age should we immunize the young girls and where can we do this? I believe that's for HPV vaccination. And then how much or to what extent does government fund treatments? If you could comment on those two.
Okay, so HPV is available. All immunization centers have. I think I immunized my daughters 10 years ago, but I know that now it's even more open. At the time I immunized, I think one was 9 and another was 10 and another was, I think, 13. But they go, I think the UNEP program allows, I think, from 8 years going up, because I think the study is 8 to 10 going up, as long as they're HPV negative. But as if they have not had any sexual contact, they go any age. So it doesn't matter whether your 18-year-old hasn't had HPV. If you report to an adolescent clinic, there's an adolescent clinic in Mulago that does all this. But also all the immunization centers are mandated to provide HPV immunization. And we shall get the benefits of this HPV immunization ahead, not now. And the costs, the government provides the basic drugs whenever, as much as possible, it provides the basic protocols. We have very many drugs at UCI. It will buy drugs for the basic protocols that we have. It is these drugs that are costing like, so it also buys drugs that used to cost 3 million, 4 million, although because we are buying a lot, we buy them at a much lesser price. But it will buy even drugs that cost 1.5. For prostate, it tries to buy the basic drugs, even for breast, the basic drugs, even the targeted therapy. But drugs that cost above 5 million a dose, those ones, I don't think it buys them. We can't afford them.
Right. A follow-on question to the HPV vaccination is whether there are side effects among the young girls. And then there's a question about the health system and how do we fix diagnosis problems or constraints in the health system that cause misleading cancer results. This person talks about someone they know who died of prostate cancer because of false test results received in India. Just your comment on those.
I don't know any side effects. I know that some children are sensitive to some of the proteins that are used in these HPVs. I know firsthand that one of my daughters got a rash that has never gone away, but it's not painful. So they can get, yes, reactions like any other immunization, but we haven't, at least I know that we haven't gotten any side effect to the immunization. I think it's looking at the bigger picture, but also let us be aware that there are people who don't want to vaccinate, who will come in with very many stories. I remember in my S1 when we were being immunized for tetanus, because there was a lot of tetanus in young children, and I think at around birth, we were told that we shan't have children. So we went for the first dose and the second dose, and the third dose we didn't get. But by the time we were coming to deliver as mothers, we knew we had to have it, and I had to report that I didn't get the third one. So I had to get double. So I think there are non-vaxxers who are going to give us all those stories to prevent us from going for the vaccination. But in fact, even the boys are supposed to be vaccinated, not only the girls, because the HPV comes on the boy's penis to arrive on the girl's cervix. So in the Western world, they're even vaccinating boys, not only girls. They're vaccinating boys and girls. But because of our poor resources, we are vaccinating the vulnerable, and that is the girls. I don't think I can speak to side effects, but I would like to talk about the policies. I think there's been a move. The government has been actively trying to make sure that we have more pathologists and more pathology centers. I remember when I first started to work at the Cancer Institute, we only had one private pathology house, and that was it was on Span House, the one for Professor Ward, together with Makerere. And Makerere had, I think, one or two pathologists, and all of them had retired. They were past their retirement age. There has been a move by government to make sure that we have more people study pathology, and they have not restricted people opening pathology houses. The issue is on control, that when we have poor controls of the results that are coming out, what we can do is to make sure that one result is read by other people. For us, when we receive results, we repeat to review them. We ask for the tissue and we review it, because sometimes we may have a diagnosis that is faulty. In the Western world, what they do is that a patient being referred with a cancer diagnosis has to go with their tissue, a reference lab that receives it, and the Cancer Institute is positioning itself to have an established a reference lab that has even the most up-to-date tests that can be done to refine the diagnosis. To refine the diagnosis. So I hope that can be done, that as we go forward and we continue accruing more pathologists and more laboratories that provide pathology services, we shall be able to get a more efficient lab service in the country. Thank you.
All right. A few more questions have come in. Do you advise people without cancer to stop taking sugar, milk, alcohol, and meat like other people are advising? There are so many things that go around, so this is one of them. What's your take on those, restricting sugar, milk, and alcohol and meat? I think you've spoken about it, but I just read the question in case you have an additional comment to that. And what's the recurrence of cancer after treatment? Over to you, Dr. Victoria.
Thank you. I would say that, yes, I would restrict, but I would not restrict in the essence of saying that don't eat, but regulate. We have a challenge that where these things are available, they are available a lot. That people have sacks of sugar, which we never had as we were growing up. The sugar was put in centrally, which meant that it was little. The meat was eaten once or twice a year or 3 times at most. And the milk was there. but it was really diluted. It wasn't a lot. But now we have somebody having access to 10 liters of milk to themselves alone in a day. So everything that is eaten in excess becomes a danger to the body because you are going to actually accrue weight. And we've seen that weight increases the risk for cancer. All the foods that mentioned above increase weight. So we restrict, meaning we eat and regulate the way we eat it. Maybe we eat meat twice a week and we don't eat like 1 kilo alone. But the truth be told is that some people go out in those bufundas and order for 3 kilos alone and they eat it. And definitely we have a high rate of obesity because we have a lot of food. And one of the most abundant resources in this country is food. So we need to regulate that. I can't say don't take milk because as we age, our bones age. And that is one of the sources of calcium to us, but we need to regulate it. The issue of recurrency, the rate of recurrency of cancer, of any cancer, depends on how well it was treated and at what stage it came. And that's why I emphasize the need for us to properly understand this cancer and know its behavior. And that's why there's surveillance that I think I mentioned that in cancer, the patients become family because you walk this journey, even when the disease is not there, you walk the journey, you will keep surveilling because for the first year, you're on your hooks. By the next year, you're relaxing. By the third year, you're like, it may not come back. But sometimes it can come back, not the same cancer, but another cancer or even another similar cancer, 5 years or 10 years over. Or you may stop treatment that should have maintained and kept this cancer at bay, and it comes back. So I'll give an example for breast cancer that some cancers we know are very aggressive. Certain types of breast cancer are very bad. We are always on the lookout. We follow up fast treatment, fast stopping treatment every year. And some of them, we don't even stop treatment. We put on a maintenance regimen, maybe for a year, then keep watching and waiting as we surveil with different tests and examination regularly done to see whether the cancer is there until we can hold our breath and release our breath. So recurrence is dependent on many factors. I can't say that the rate is high, but as I said, that one of the biggest risks to getting cancer is you having had cancer, which means that if someone has suffered cancer, they should be in the lookout and they should
Hello,
have
we
regular
seem
screening. Hello?
you can go on. We had
Hello?
lost you there for a few seconds.
Okay. So that is it, that it depends on the type and how it was treated, and everybody who has had cancer should be with close relationship with the people looking after them, the purpose of which is to quickly diagnose if it comes back or to follow up and see that it doesn't come back.
All right.
And we do a maintenance therapy for certain cancers to make sure that it doesn't recur, that we maintain the remission. Okay, thank you.
Yes, thank you very much, Dr. Walusansa. We are 2 minutes to the end of our program today, and I do not see any new questions or any hands up. So I'll hand back the session to the moderator.
Thank you.
Thank you, Dr. Philippa. Thank you, Dr. Walusansa. We are immensely better off. We can now know the importance of one having, you called it a treatment buddy, and
Yes.
not being shy about our symptoms just because we are old. We should voice out and insist, kulemerako, that we get checked. And to the younger ones, please be more kind to the older adults. When they complain, encourage them to go to seek medical attention as early as possible, because we've seen it gives better outcome and improves quality of life, and it can be cost saving. If you handle the cancer early enough, it is a lot easier than when it has gone all over your body. I particularly liked the explanation on PET scan because recently I lost a friend and she was being handled in advanced countries, but they moved from one treatment center from UK to Switzerland because they were told that this PET scan is going to treat the cancer. Generally, you just get put inside there and then all the cancers wherever there, the cancer cells are treated. But I think that was a misinformation, and certainly the patient we lost that patient. And you know, you can't imagine that even people abroad where treatment, surveillance, and all the care is maybe a little better than us, get misinformed. So let us keep ourselves informed. Don't wait for symptoms. Reduce those foods which support the diseases, like the too much fat, too much milk, too much fatty meat, as we have been told. And don't forget that when someone goes and gets that diagnosis, the impact on the head, the thinking psychologically is big. So accompany them and don't take over their illness, please, because we've seen people who say, this is my breast, you are my woman, this is my breast. I'm not going to allow the treatment of cutting your breast off. It's a very sensitive thing, but these things happen. When you accompany the patient, remain humble and supportive. Remind the patient what the doctor had said and what suggestions the doctor had said, but don't take over their illnesses and make your own judgment and resolutions over their body. I am particularly happy that most of the sessions we've had before, like nutrition, exercise, and finance, actually are coming in to be very helpful to the caregivers. And I think we are planning to have some more on financing, because as we've seen, this treatment is a long-term treatment and it's very expensive, and both financially and psychologically. So we need to be trying, let's try to tie these sessions we've had before and make sure that when we get the conditions, or as we are looking after the aging people and ourselves when you are still in 40s, pick up the lessons from here and use them. I didn't imagine that at 40, it will be very, very useful to get the men screened for prostate cancer. It is becoming so common. So let's encourage the young boys of 40 to get screened as soon as early as possible. Caregiver support, we've seen the importance. Thank you so much, Dr. Victoria, for emphasizing this. And I know we have some caregivers online, and all of us are caregivers in one way or another. Please take your role as serious and very helpful as you help to purposefully age. Thank you so much. I do not have the topic for next month, but we shall be here at the end of March, the last Saturday of March at 10 a.m. to tie up more loose ends in our purposeful aging. Thank you so much, everyone. Thank you so much, Dr. Victoria. We've been very, very well educated this morning. Thank you and bye to everyone.
Thank you.